Most exciting, as we've now also discussed here, is this importance of considering data that's outside the electronic health record. In the emergence of value-based care, where both providers and payers have a shared interest in delivering high quality care and reducing costs for not just HCCs, but other chronic conditions, we do recognize that payers may be a source of information for providers to consider. And one such source of that information could be claims data, for example, or clinical review. So a health plan, for example, may have seen a diagnosis code on a claim that came from another health system, another ambulatory practice, and is not yet visible within this particular physician's purview. This type of recommendation can also be presented to a physician in workflow. Now, along with clinical evidence as to why the payer thinks this should be considered. This type of interaction is based on an integration that IMO is building out with our health plan customers today, our health plan partners today. In terms of how this functionally works, our health plan customers share member rosters with targeted member interventions, such as risk adjustment suggestions. IMO will then match those members prior to an encounter so that we can identify whether that encounter is appropriate for an intervention. And we manage that interaction behind the scenes, and we effectively then report data and help both the payer and provider understand whether or not those risk adjustment suggestions were acted upon and whether or not there was an improvement in terms of the patient documentation. At the heart of everything IMO Health does, of course, is driving specificity. Imagine this clean, comprehensive problem list is now available to a physician. There is a final step that's imperative if a physician were then to consider taking action on a particular condition, such as a hierarchical condition category, such as diabetes. In order to add that diagnosis to the list, this is an implication regarding our modifier workflow. We recognize it's not sufficient in today's world for a physician to simply record diabetes. It requires additional levels of specificity regarding things like long-term insulin use or complications. In order for us to facilitate a nice, clean, highly specific documentation exercise, in which case a physician doesn't have to understand all the implications from a coding perspective, we will navigate the recording of appropriate information. So imagine in a diabetes situation, we will guide the physician to notify whether it's type 2, whether there's long-term insulin use, whether there are complications, and then when you get into the complications, an ability to specify the necessary staging and so on. Once that additional level of logic is applied, a variety of codes are applied to the visit. Number one on the list is a much more specific, highly specific representation of diabetes. Secondary codes that are required for chronic kidney disease and long-term insulin use are automatically applied as well. That gives a physician the most comprehensive representation of a particular condition and maximizes reimbursement.